Hello, good morning, good afternoon, good evening from whichever part of the world you are watching us. I am Dr. Sivakumar, heading the Pediatric Cardiology and Adult Structural Heart Disease Division from the Madras Medical Mission, Chennai, India. So today we have an interesting transcatheter intervention. In the recent times, there is an increasing interest among the interventional cardiologists to do a non-surgical closure of sinus venosus defects. Sinus venosus defects are basically a defect in the superior venocaval to right atrial junction and intraatrial communication that causes a left-right shunt and is often associated with an anomalous pulmonary venous connection. There is an increasing interest for a transcatheter closure using covered stents. So I have with me my colleague Dr. Tejasvi, who is going to give a small PowerPoint presentation about the case. I would like to introduce the other people here. It is Dr. Pramod Sagar, who is the imaging specialist. Dr. Fareen Qureshi is our final year fellow who is going to assist me. Sister Jay Chitra and Nadira, who are the circulating and scrub nurses, and Prabhu and Surya, who are the technologists. Over to you, Tejasvi.
Our case today is a 28-year-old lady who's the mother of one child. She was incidentally detected to have a sinus venosus defect during routine evaluation. Apart from NYHA class 2 dyspnea on exertion, she does not have any symptoms and no other comorbidities. On examination, she had stable vitals with mild cardiomegaly. CVS examination showed a wide split second heart sound with a grade 2 ejection systolic murmur in the pulmonary area. Her chest X-ray showed mild cardiomegaly with a CT ratio of around 60% with a dilated MPA segment and pulmonary plethora. This is a 12-lead ECG which shows a normal QRS axis and an RSR- pattern in V1 suggestive of RV volume overload. This is the echocardiography where in the 4-chamber view there is RV volume overload with dilated RA and RV, and in the subcostal view you can see here that there is a sinus venosus defect. This is the cardiac CT which shows a single SVC with the RUPV draining into the SVC at the SVC-RA junction. This is the sinus venosus defect seen in an axial cut. And here also you can see the sinus venosus defect in the sagittal cut. The SVC diameter just above the SVC-RA junction was around 20 into 19 millimeters. As sir was saying, the basic anatomy in a sinus venosus defect is a defect in the common wall between the RUPV and the SVC, causing a left to right shunt. And transcatheter closure is an emerging treatment strategy. Our center has the largest experience in the world and we have performed around 80 successful cases so far. So the transcatheter closure involves placement of a covered stent in the SVC so that the defect in the common wall between the RUPV and the SVC is closed and the RUPV blood is routed into the LA. The key is to choose an appropriate size stent. Too large a stent can cause obstruction of the RUPV and too small a stent can lead to a residual. We did a virtual reality reconstruction of the CT of this patient, and as you can see here, this is the RUPV opening out into the SVC-RA junction. A virtual covered stent was implanted, and in this cranial aspect, viewed from the cranial aspect, you can see that the RUPV is routed into the LA with the placement of the covered stent and the defect is closed.
Yeah, here this is the same image with the color. We can see here the sinus venosus defect is opening.
So now this is the right femoral vein that we are accessing. We put in a standard 6 French introducer. I'm going for the left femoral venous puncture. So we are, the vascular access is completed. So we have 2 vascular access now. Diagnostic catheter, Judkins right 5 French with thermowire. So I'm taking my catheter through the left femoral vein. We are going through the inferior vena cava. So as we are coming into the right ventricle, we will plan a transeptal puncture in the fossa ovalis, transeptal needle with contrast. So we are introducing through the transeptal sheath. We make a transeptal puncture at this point, tenting the septum here. So this is in the left atrium, and now we are withdrawing. So now we are getting our diagnostic Judkins right coronary catheter into the left atrium, and we introduce our guide wire till I am pretty close to the intraatrial septum. I'll try to divert this right coronary catheter more towards the right atrium. At this point, I advance the guide wire into the right upper pulmonary vein. So this position looks good. Again, flush this catheter. Now get me the pigtail inside. Hold the wire.
Catheter is into the right upper pulmonary vein.
Oh, that's nice. Across the sinus venosus defect, take the color out. So through the right side, now we are advancing the venous catheter. So this is a marker pigtail that goes into the superior vena cava. It is draining into the right atrium. Come towards me. Ready for the injection? So here, this is the right upper pulmonary vein. So now the next step that we are going to do will be, we're going to be connecting to the superior vena cava. Table little down. Yeah. Ready for injection? Shoot. Next step, that is balloon occlusion. Thermo wire again. I want the Judkins right again. So the Judkins right diagnostic catheter now goes into the left innominate vein. Track the vein. Okay. Keep going.
Okay.
The patient's hand is abducted. So come back to the heart. Yeah. We take out this diagnostic introducer sheath. Dilatation of the groin puncture wound. So I'm introducing this small graded introducer. The introduction of the 20 French long sheath. Remove this. So now we are withdrawing this, aspirating the blood. So we are going to now flush it.
Now the balloon will come and occlude this, and then we will see live whether these color flows or not, and how the RUPV is routed into the left atrium.
So the balloon has come, the balloon has entered the superior vena cava atrial junction. At this point, can you go live, Pramod, with your color flows? Yeah.
We're
So
going-
now we are seeing the left-right flow. Can you demonstrate the left?
Yes,
Yeah.
yes.
Sinus venosus defect is centered on the heart, on the image. Yeah. I am now making an inflation of the balloon. Keep it pushed in.
Of course.
Tell the number, please.
See, as we are inflating, we can see here on the left side of the screen, the balloon is getting inflated.
So now you are able to demonstrate the long cylindrical balloon across the superior vena cava. Now when you enable color, without color compare, as absolutely there is no left-right shunt at all. So at this point, what I'm going to do is make an angiography
And we-
of the right upper pulmonary vein. So now I'm going to make an injection. So we are able to see only the left atrium filling. There is some holdup of the contrast in the left upper pulmonary vein. This pulmonary venous pressure is now 12 to 13. I'm disconnecting this and connecting it into the left atrium. Left atrial pressure is about 10 millimeters of mercury or 9 millimeters of mercury.
minimal turbulence, but however, there was no significant gradient when I did a pulse wave Doppler.
So Pramod, at this point, I'm going to deflate the balloon so that you are able to demonstrate the left-right shunt that is going to start. So keep the color on. I am deflating now the balloon fully, and as I deflate, you should be able to demonstrate the color flow again
Yeah, we can see now the color flow starts.
Demonstrate the atrial septum, the cranial end a little bit.
Yeah, here.
Yeah, so that is the right left shunt. That is a left right shunt. This patient's sinus venosus defect is going to be closed by a 24 millimeter covered stent. So what we'll do is we will take out this balloon, just recheck the pulmonary venous flows and the sinus venosus defect flows. Yeah, now we are able to clearly see that there is a left-right shunt through the sinus venosus defect. I need two indiflators, one for the inner balloon and one for the outer balloon when I am. So we are going to be, in order to allow a pulmonary venous protective strategy, I'm going to advance an Amplat super stiff guide wire into this pigtail that we have already positioned in the right upper pulmonary vein, and I am taking out the pigtail catheter. I will flush the Mullin sheath. So this is so the Mustang balloon is now across the SVC, across the right upper pulmonary vein to LA junction. So this will be ready to get inflated whenever my covered stent is going up. So now we will start processing the covered stent. So we have taken a 24 millimeter balloon for the interrogation, covered Cheatham platinum stent. This is a 10 zig stent. So this stent now comes with a bib balloon. Yeah, 24 into 7. So this is a pre-mounted covered stent. It has got two balloon ports and one lumen port. So the lumen port is green in color, which I am flushing now. Now there are two other color ports. The blue color is indigo. So the indigo is for the inner balloon. The orange is the O. Orange is for the outer balloon. So O orange outer balloon, I indigo inner balloon. So I'm connecting now a small indiflator filled with contrast, full contrast. So this is now connecting the smaller syringe onto the inner balloon. I want now outer balloon. Yeah, an indiflator for the outer balloon. Can you show that? The balloon inflation sequence. It's a 8 centimeter balloon. Balloon on the pulmonary vein. So we should be able to get an occlusion. Now I have taken a 7 centimeter stent so that too much of protrusion into the right atrium is avoided. What we'll do is, once I inflate the inner balloon, you will tell me how much of stent protrusion is there below the lower end of the sinus venosus defect. So based on that input, then we will adjust the location of the covered stent. So that is the advantage of this bib balloon, so that I can inflate the inner balloon and the stent will still not be attached to the walls of the superior vena cava, and I will be able to adjust the position of the stent. So it is fully DR. Okay. So we are all set. The covered stent is nicely gripped around the balloon. We put in a protective sleeve in order to avoid the stent from getting distorted in the valve of the 20 French long sheath. So this whole assembly now goes through the Landerquist wire. So we will continue with the same dose. So I have taken the protective sleeve out. I am taking the stent across the pulmonary vein. At this point, I will check where is my pulmonary vein by a contrast angiography. Dye. Okay. So this is going to be telling me the position of my pulmonary venous sheath.
You are planning to inflate the Mustang after the inner
After
balloon,
that,
sir?
yeah, because the inner balloon Mullin sheath is okay. It's well below. So now I am inflating the inner balloon entirely. Yeah, that is the that is the stent. So now I am
Quite
going to
close
make
here.
another injection on this right upper pulmonary vein. So I have got
Position looks good.
a decent protection. So at this point, I'm going to come out of the, so I am giving the protective balloon inflation. This is the Mustang balloon from Boston Scientific. I am inflating. So this is inflated to almost around 12 atmospheres. Now let us see the lower end of the stent, Pramod.
Yes, sir. This is the region of sinus venosus defect, and it is quite lower down, and we have a at least 2 to 2.5 centimeter below that.
So that is my sheath in the left atrium. The Mustang balloon is now across the right upper pulmonary vein, and we are now ready to go with the outer balloon. So now we will take the outer balloon. So now I am inflating the outer balloon. The flow across the sinus venosus defect. Is there a flow? Oh, that is a flow.
There is
Right?
a flow here. Now
Yeah.
here on the rightward edge, I can see a flow.
So I'm now progressively inflating the balloon, the outer balloon.
This now we don't see any much color actually. And
Okay.
not,
Okay.
there's
I
no
am going to
significant
now
flow here.
deflate the balloon. I am deflating the inner balloon. Go to 0 degree and then check. Now I am going to be deflating my right upper pulmonary vein balloon. I'm gently advancing my right upper pulmonary vein sheath into the pulmonary vein and taking in the Mustang balloon. Hold it here. So I'm taking out now at this point the Mustang balloon out.
We are
Can
in
you
the
show me now the
level of
color
SVC.
flow? Correct. That is the right upper pulmonary vein draining into the left atrium now.
Pointer.
Now come to the middle, keep the stent in the middle. So that is the stent across the SVCRA junction. The right upper pulmonary vein flows are looking laminar.
Yes.
So it's quite laminar.
Quite laminar flows.
Okay. So that is the left atrium. And slightly pull out the probe, please. Rotate it to about 100 or so that the stent becomes long in real long axis. We are able to see the wall of the stent. Yeah. So on the top, what you see is the left atrium. That is the stent flows. It looks quite good. So at this point, I'm going to make an angiography. So this is an angiography from the sheath. It's clearly demonstrating that. Show this picture. It's only filling the left atrium. Stop it. When the right upper pulmonary vein is draining into the left atrium, stop it. Yeah. Go forward, forward. So absolutely no flows from the left atrium into the right atrium. And now at this point, we have clearly shown that there is no flows. So we will be having the left atrium and left ventricle on one side of the screen and right atrium and right ventricle on the other side of the screen. I'm going to inject now.
Here.
So this is completely filling the left atrium and not filling the right atrium at all. So the position of the stent looks satisfactory. The next step, we will take out this balloon. So the balloons have been deflated. So I'm ensuring that the balloons are totally deflated. So the balloon has come out. We will now de-air the sheath. So can I get that marker pigtail again and take out this Landerquist wire. So the Landerquist wire comes off. Okay. We are ready now for about 15 ml at 15 rate. So that is the superior vena cava that is filling the right atrium through the lumen of the covered stent. Echocardiography. Yeah, that's a good view of the right pulmonary vein.
This is the
Show
right
that now color the right pulmonary vein.
This is the right pulmonary vein there, and we can see the
color
wire
up.
still there inside the right pulmonary vein.
Okay, now show the sinus venosus defect.
Now I'm decreasing the rightward torque, and now we can see that this is the region of sinus venosus defect that has been completely closed by this cover stent, and this is the lumen of the stent. And if I color here, there is no flow from the left atrium into the right atrium, and the flows inside the stents are the flows through the stent from SVC.
Thanks a lot. That was a beautiful demonstration. This was a good right upper pulmonary venous rerouting into the left atrium. Freeze it when the right upper pulmonary vein and the left atrium are seen. We can see the entire region of the fossa ovalis. We can see the entire left atrial wall, the atrial septal part, and the right upper pulmonary vein draining into the left atrium. So that was quite good to see. So now I'm going to be removing the stiff guide wire out, and I'm going to be removing the Mullin sheath out. So I'm going to be removing this pigtail now.
There's some restrictive flows through that region.
So that was the color flow through the septal puncture that we have made. Yeah, initial bite below the sheath, and then crossover and take another bite above the sheath. So this is a size 2 silk which will be removed about 6 to 8 hours later. I'm taking a second bite just to reinforce the previous stitch. The sutures go almost on the same lines. So this is the second layer. That is Anavin. Yep, thank you. So this is now the figure of 8 has been placed. In order to make that area once again anesthetized, I am infiltrating bupivacaine injection, a local anesthetic. I'm making a double knot. Okay. So we have now got a right femoral venous sheath, a figure of 8 stitch, which is going to give some amount of hemostasis. And now let us relook at that last pulmonary venous angiogram that we have done with the 8 French Mullin sheath in the right upper pulmonary vein. Here we are able to find on angiography that the right upper pulmonary vein is completely routed into the left atrium